All right. It's telling me recording in progress. Okay. Hi, I'm Sandy Werner, and I'm one of the leadership group for the Probing the Literature Journal Club. And thank you guys for coming. I really appreciate having you here. Today, we're going to do the renal session of the Journal Club. And kind of the way this works, we'll start with a little introduction and welcome. So I welcome you all. And then we'll go through an article, and that's with Dr. Moore, and he's going to present an article and talk about it, and we'll have some time for question afterwards. And then we'll I'll run through how our small group process works. And then the second article will be done in small group discussion. And then we'll come back together very briefly at the end. And then for those of you who can stay for the method consult, and this is really great if you're thinking about or somewhere in the middle of a research project, this is a time for you to get some help on where you might be stuck. So that's how it's going to go today. So the first article is the Annals of Emergency Medicine article on the effect of provider experience on clinician-performed ultrasonography for hydronephrosis in patients with suspected renal colic. And I'm very happy today to tell you that we have Dr. Chris Moore with us, who's going to discuss this article. So Chris is a professor of emergency medicine and the chief of the section of emergency ultrasound, and also the director of the Emergency Ultrasound Fellowship, and he chairs their point of care ultrasound council at Yale. So Chris has been doing ultrasound for many, many years and has written over 90 publications and in JAMA, NEJM, and British Medical Journal. He's been continuously funded for research, and I'm really happy that we have him here today to talk about this article. And the article is, that was the article. Clumsy today. Okay, so we'll go ahead and move on to the article, and I'm going to turn it over to Dr. Moore.
Okay, good afternoon. So Sandy, just tell me real quick, I know we have 20 minutes. How long do you want me to, I have a little presentation, or, I can just talk when we can discuss, or?
Why don't you go through the article? Just go through kind of each section and then ask folks at the end if we can have about 5 minutes for questions. That would be great.
Okay. So first of all, thank you so much for the invitation. It's great to see some familiar faces that I haven't seen in a while. And Sandy, I don't know when the last time we saw each other.
I don't know. It's been a long time.
And Elizabeth Schoenfeld, I see, who's been active in this area as well. So, and I'm sure some new faces and new fellows. So I'll take you through this real briefly and maybe put a little bit in the larger context of some of the research I've done in this area. I want to acknowledge Megan Herbst, who was the first author on this paper, who was my fellow at the time. She's done fantastic stuff. You may know her at UConn at this point. But we published this back in 2014. And just to give you some background, it was actually one of my earliest fellows, a guy named Scott Bowman, who really pressed me on the whole kidney stone thing. He's like, why are we seeing so many kidney stones? We should be ultrasounding. I'm like, you're right. How do we figure out how to convince people to do this? And I applied to American Healthcare Research and Quality Institute, AHRQ, and I had done research before, but I hadn't had big grants, and I kind of hit a home run on the first grant. I got an R01 from AHRQ and followed that with another one, and that kind of led to this work. So, I'll tell you just briefly that what we did is from July 2010 and November 2012, we were prospectively enrolling patients in our emergency department who were going to get a CT scan for kidney stone. So they were scheduled to get a CT. So we had RAs in the ED, and this is what really made this possible. We were able to enroll, over 600 subjects, and the only way to do that reliably, in my opinion, is to have some help. So this was not the primary goal of this project, but it was something we certainly were interested in. So we had RAs in the ED. And as soon as they identify somebody who's going to CT, they would set up the machine, they consent the patient, and they get the operator in there to do the scan. So it was fairly smooth. As you know, renal colic study really doesn't take that long once it's all set up. And then we asked them, did they see hydro? What was the degree of it? We divided this group. I think we had 44, or we had more than that, like unique providers. But we had 4 groups: attendings with fellowship training, attendings without fellowship training, non-attendings, which were typically residents who had had at least 2 weeks of an ultrasound rotation, and then non-attending inexperienced, meaning it tended to be APPs or residents who had not been on rotation. And Sandy, if anybody wants to stop or throw things in the comment, I'm happy to pause at any point and take questions on this stuff. Just let me know. Skipping really basically to results, we can talk about other methods and stuff, but we had 670 subjects. They tended to be in the 40s, pretty even split, male, female, mix of ethnicities and races. This is our star diagram, and basically, ultrasound was not interpretable in about 9, but then of the ones that were interpretable, it broke down about half hydro, no hydro. And then within those were, whether they had hydro on CT or not. So that's how we get our kind of sensitivity, specificity. This is a diagram. Actually, I say I borrowed, maybe stole this from Jeff Klein, who you may know from PE research. He was my mentor at Carolinas Medical Center. He did a study on DVT. I'll show you that figure, but using a similar approach here, which is basically, how many ultrasounds did these people do? And then, what came in as true positive, false negatives. And we'll talk about sensitivity, specificity, but, you'll see that the fellowship training ones, there's a lot more green. The attending physician without ultrasound fellowship training, there's a fair number of the reds, which are false negatives. And I think actually I'd probably prefer to have a false negative in this sense, in that they were more specific when they identified it, meaning if they said there was hydro, there really was hydro, and that actually may be more helpful in this situation. But you break it down. Actually, this is the figure that I stole from Jeff Klein around DVT study, which is also a really interesting one back in 2008. It's a good one to know about as far as the effective provider experience on diagnosing DVT. This is the data. It's a little bit busy. I should have used something to highlight it a little bit, but you'll see that there's sensitivity, specificity for based on the level of any hydro. One thing I want to highlight is that middle group, which is moderate hydro, and I really do believe moderate hydro is within the purview of many people to identify with or without like specified training. And you'll see even attendings without fellowship, they were like 98% specific, meaning when they said there was moderate hydro, it truly was there. Mild hydro was the one that was harder. And if we have time, I have some images we can look at and things like that. But where you'll see that the fellowship training made a difference is in the last one down there. You've got sensitivity, specificity that's quite a bit higher if you have fellowship training. And I really think that that's because of the accuracy of identifying mild hydro, which is an area that can be overcalled by people who don't know what they're doing. And then these were the overall results, which we can go through. Just to put a little bit of actual real images to this. This is an example of a patient that we see the kidney, and the calyces are prominent, and sometimes you'll see the radiologist will hedge about pelvic calyectasis or something, which is a hedge for mild hydro. But I don't think this patient actually really had hydro. And as you guys are probably aware, if you're doing much ultrasound, that next thing you might do is throw some color on, and we'll show that. This is what I would consider to be true mild hydro. Again, I would throw a color on here to make sure that that's not vasculature, but it looks like there's actual dilation into the renal pelvis. And here's color, right? So you throw that on there to make sure that the anechoic areas you're seeing in the kidney are not blood flow. In this case, they are blood flow. It tells you that it's really not a dilation of the collecting system. And the thing to note there is the scale in the upper right? You want to adjust that appropriately to, make your sensitivity good enough. You want to lower it, but you don't want to get too much artifact. And we can also talk about any techniques if you want. Here's an example of hydro with color flow, right? Where you can see that there's an area that doesn't pick up, but it's dilated. And that's how, you can help use color to differentiate hydro from vasculature. How about this one? Any brave souls? I don't know how interactive this can be, but this is an example of one with a peripelvic cyst, right? So there's a cystic structure that's adjacent to the pelvis of the kidney, but it doesn't really extend up into the calyces, and that's the difference. And even very experienced, sonographers, radiologists can mess this up. But it's a pitfall, and that's why the sensitivity specificity is probably never going to be completely perfect. But there are pitfalls in doing this. Here's an example of severe hydro, and I just want to point that out. We had very few severe hydro, and when I see that, that's not just a kidney stone, or if it is, it's a kidney stone that's been there way too long and really has killed the kidney. So you see severe hydro, you do want to follow that up. This one, you may know what this is. This is a fornicele rupture, calyx rupture, and you can see fluid outside the kidney. Remember the first time I saw or diagnosed one of those, I was like, oh no, it's going to be terrible. They're going to take it to the OR, and the urologists were not impressed. It's just something that happens and actually can relieve their symptoms. It's not a big deal, but you'll see it on ultrasound from time to time. And then I would encourage people to look closely at the bladder, particularly the UVJ. Here's an example of a pretty large UVJ stone. You can see it shadowing, kind of pooching into the bladder a little bit. And you can apply, color there, and you see twinkling artifacts actually pick up that stone. This ultimately led to, a clinical prediction rule that we came up with, a stone score, stone plus, which with point of care limited ultrasound. This is under fire currently because of the incorporation of race as a variable, and that is controversial at this point, but it was one of 200 variables that popped up when we put all our stuff into the the algorithm. Was one of the top 5, but we are actually looking at revising that with the removal of race. So that's a little bit of a whirlwind tour of that stuff. This is the MD Calc thing, which has the race disclaimer on it at this point. But I continue to be, I still think that kidney stone is super common. We probably do far too many CTs. It's an area that I think still merits some research, and I'm happy to open the floor for questions, discussion, whatever you want to do.
I have a question, Chris. I generally teach our residents that they should allow the patient to get some IV fluids prior to this ultrasound. Did you guys standardize that at all, or what's your teaching at this point? I actually don't know the literature behind that, but that's what I advise people to do.
Yeah, no, it's a great question and comment. We wanted to enroll these patients as quickly as we could before they got CT results in order to keep the blinding. So we did not control for fluid status. I forget if we looked at it. It would be worth looking at to see if there was a difference, like if there was a higher sensitivity for or prevalence of hydro in patients that got hydration before we did the scan. You'll see different things on that anecdotally. Some of the urologists will get upset with you for giving fluids because they think it's going to cause more pain and stuff like that. I do give fluids to patients with kidney stones generally, and I think it does help to identify hydro, or we can talk about ureteral jets or things like that, but other things that can help exclude it. So it's a great point, and I in the busy emergency department, I don't standardize that. I do give fluids. I think it probably, I don't know that if there's great literature on that, but I think it probably will increase hydro if you really hydrate somebody and have an obstructing kidney stone. I've had some cool ones where you hydrate them, you're looking at it, and I've actually seen the stone pop out of of the UVJ while we're scanning them, which is kind of cool. But in any event, yeah.
Yeah, that's a really good point. And I have not ever seen any study on whether, randomized controlled study on where you're giving people a liter of IV fluid and not, and seeing if it makes any difference. It might depend on their prior hydration status or how obstructive the stone is. But yeah, I'm not aware of anything. That's a nice study that perhaps someone could do. Yeah.
I mean, I guess the thing I liked about this study is it actually does, give some credence to fellowship training. You guys who are in fellowship, you're not, you're going to get better at things, and we have actually, some evidence of that in this case. But so I liked it. It was kind of an offshoot of our main study, but it worked out well. So.
All right. Other questions, comments?
I have a quick question. My name is Mike Jones. I'm one of the fellows at VCU. Thanks for sharing your work with us. I just was wondering if you could talk a little bit more about the actual process that you went through to enroll the patients. Like, did you depend on the treating physician to identify patients that were eligible, or what was that process like? And then you mentioned it, I think, a little bit in the talk, but if you could just go into more detail, I think that'd be helpful.
Sure. I mean, again, the way we were able to do this in a way that we, prospectively enrolled a large number of subjects was that we had the funding to have a research associate, in the emergency department. And we also had a flag in our Epic system where if somebody ordered a CT, it immediately alerted them. So they knew right away, and they would kind of circulate in the department and say, hey, anybody have a kidney stone they're worried about? But it wasn't until somebody actually ordered the CT that they really rolled. And so that, that helped we were able to automatically identify them. And as soon as they saw that, they would go to the patient, say, would you be willing to have an ultrasound if they hadn't had one already? And there might've been some that had an ultrasound done previously, but if they hadn't had, either way, we did a study ultrasound so that, having the RA able to consent the patient, which takes a little time, and then you have to do it right. You have to, with the IRB, there's no way we could have had like 60 different providers consenting patients, right? So then they would actually set up the machine so that the provider actually just, all they had to do was duck in, pick up the probe, look, tell them whether they thought they saw hydro or not. So yeah, that was our process. When you're starting out in research and, you're doing your own stuff, it's challenging, right? And I've done that. I've done studies where I enrolled all the patients myself. But long term, like research and data is about numbers, and to get numbers you got to get a lot of patients over time, and that takes persistent work, and it's probably not the most efficient to have like the person who's designing the research get all the data there. So there's a lot of studies in the ultrasound literature that are kind of done by people who are very motivated to do ultrasound, and that provides a bias, right? So if the only people who are enrolling patients are your fellows who really love ultrasound and they're good at it, this is trying to be a little bit more democratic in the sense that we're grabbing anybody who is seeing a patient with kidney stone, and regardless of whether they typically would do an ultrasound or not, they do one and they tell us their interpretations. So I think it's a little bit more representative of the general people who are practicing emergency medicine, rather than some of the studies you'll see in the literature, which are very, they're honestly biased. They're good. I mean, it's important to do that study to show that somebody can do it. But when you want to generalize something to all of emergency medicine, ideally be enrolling subjects with everybody using ultrasound, not just the people who are really into it,
Right. And you'd also want to really have as few exclusions as possible if you're going to try and generalize a study to all of emergency medicine. So to make, it's practical for all patients, because if you do it really tightly controlled and you have all these exclusions, that's not how it's going to work in the real world. And we're going to actually talk about that with the next study, the type of study it is, and discuss that a little bit. Chris, there are two questions from Matt Nelson in the chat. The first one is, was the time between ultrasound and CT standardized?
Okay, good question. Hi, Matt, how you doing? We did not standardize it, no. We did blind it, like if a provider knew the result of the CT prior to the ultrasound, we would not have that provider do the ultrasound. There were times where that happened and we found a separate provider who was not caring for the patient directly, who did not know the result, to do the ultrasound. But again, as Sandy was saying, I mean, in the real world, when you're doing this stuff and you're trying to capture as many numbers as you can, and have a real world sort of applicability of this, it would have interfered with clinical care or limited our numbers if we had tried to standardize it. So we really didn't do that. And the other question is, CT a better test for hydro than ultrasound? Questionably inferior. It's a great question. And yes, CT, can certainly, I'm not sure it's great for hydro. It was sort of the best gold standard we could come up with, because very few of these patients were getting like a radiology ultrasound, which arguably could be your gold standard. But it's a good point. Not all patients with kidney stone have hydro. and the radiologists, when they read the study, if they see a stone, they may kind of like overcall hydro that they might not otherwise have called. There were, I think about, there was a subset of patients that had hydro but no CT, and other ones that had stone. I'm sorry, hydro but no stone, and other ones that had stone but no hydro. And so I don't know, Matt, if that answers your question. And I'm looking at the chat here as well. Jason, Arthur, any thoughts if test performance loop diuretic? Another question that kind of relates to the fluids question, I think, but we did not parse that out. And Elizabeth says on a diuretic, small number, and then buy-in by the urologist. Yeah, I actually, one of the there's a co-author on this on the paper, Dinesh Singh is a urologist that I work closely with here, and he, he's a big fan of the point of care ultrasound. But yeah, there are varying degrees of trust around that. We put all of our images on our PAC system, and they can look at it, and urologists getting more familiar with that. But it's variable, it's not just one urologist, the whole group of them and different ones. Honestly, we'll talk about the Smith-Beinman paper, but I got involved with that at the national level, and the urologists, I think legitimately will tell you that before they see a patient in their clinic, they want a CT. And that's not unreasonable in my opinion. It tells you about stone burden, how big the stone is, where it is, all the stuff they really need to make a plan. So, I think point of care ultrasound is very good for finding these patients that are, going to do fine. You have a diagnosis, it's not anything else serious. But if they really do need to follow up with urology, I don't, I'm not anti-CT. It's just a question of when to use it best and how to use it, most efficiently.
Yeah, I think we tend to ultrasound those folks who have had a bunch of CTs, and you already know they have stone disease. So you want to just know if they're obstructed versus, they have a stone and they have pain and they're not infected, they're not obstructed. I'm pretty much done. But then if they're obstructed, then I probably need to go another step to satisfy the urologist.
Although I push back a little bit on obstructed because, really, if you have hydro, it's obstructed, right? And there's many small stones that, would be considered obstructing. And most of the stones that are symptomatic are actually obstructing, right? So I don't like the term obstructing. It really is about size.
Right.
Size matters here, right? Is it, more than 5 millimeters? And there's a whole other body of work we did on ultra low dose CT, which is another way to identify stone size while minimizing radiation. But it is a question of size, and the majority of patients that have had stones and passed them before are going to do that, but it is hard to know without a CT in most cases unless you can see a UVJ stone. So I go more by symptom control. Like if they're unable to relieve their symptoms in the department, I usually will move on to a CT to delineate stone size.
Mm-hmm.
And if there's infection.
Yeah,
So.
yeah, definitely. If there's an infection, I agree. All right. And then, oh yes, we addressed the buy-in by the urologist. Any other questions, comments? All right. Thank you very much for joining us, Chris. And you're welcome to stay for the small group discussions and join a small group. That would be terrific. Yeah, if you want to come back and moderate small group sessions, let us know in the future, and we'd love to have you.
No, thanks for inviting me. I got blocked till 3. I can stay for a little bit. So
awesome. That's great. Okay, so we are going to move on. I'm going to share my screen here. We're going to move on to the next article, which is, this is a really classic article from the New England Journal on comparing CT versus ultrasound for suspected nephrolithiasis. And there's a lot of great authors on here. And I actually just got forwarded yesterday a journal pre-proof from the American Journal of Emergency Medicine. They've actually taken the this study and made it into a clinical decision tool. So it's the effect of an ultrasound first clinical decision tool in emergency department patients with suspected nephrolithiasis. And it's a randomized controlled trial, and it kind of builds on this paper. I would recommend everybody to take a look at that. I kind of wished I'd had it a little earlier. I might have included that as part of our formal discussion for this second article. All right. So the way this is going to work is that Dan, who's our master, our Zoom master. We don't have a Zen master. We have a Zoom master, though. And that's Dan Mersch. And he's going to divide us up into groups. And the group leaders have all been given a brief guide on the article. So we can provide a brief summary. And then we'll have kind of a discussion. And one of the interesting things about this article is that it's considered a pragmatic study. So the idea is that it's more generalizable to the whole population of patients in the ED. So it's kind of a different methodology that people might be not as familiar with. So I thought it was a good article for fellow discussion. And with that, thanks for coming. Okay, that was a quick exit. I knew he had to go to shift, but we need our Zoom master to do that. So we'll give Dan's group a few minutes to think about what they're going to talk about, and I'm gonna have somebody from Mike Gottlieb's group tell us kind of their main points.
Throwing us on the fly. All right, that's cool. I can talk about a couple of things that we highlighted specifically in terms of methodological aspects of the studies. One, we talked about just the role of pre-registering these studies in clinicaltrials.gov. That often gets some kind of overlooked sometimes, and particularly in ultrasound, where some things aren't thought of as traditionally as interventional as some of the medication-based trials or things where we're doing a physical procedure. And just that this registering clinicaltrials.gov, it's a way of having transparency, just kind of showing this is what we tend to do. So if something doesn't turn out the way we wanted it to, there's transparency, you actually have to report it. So that was one of the things we, thinking through for making sure that when you're doing study designs that are going to have a interventional or somewhat interventional component like this does, that you're including that you're registering it somewhere. Then the other thing we talked about, or one of the other things we talked about, was they did a good job of describing randomization, saying that they randomized patients, they used the program to ensure that, but we didn't see as much, and then we was to describe more about allocation concealment. And just broad strokes, we talked about the role that the idea that it's great if you randomize people, but I can still pick from the randomization sequence and just skip my order. If you just leave a table on, you're saying you're randomized for 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 1, 2, I can just opt to take a different spot. And the goal is if you're going to randomize people, that you should be able to skip the line and pick the option you want. So it doesn't matter if they're randomized. The randomization is just globally across your site. By concealing it, you're eliminating that portion. So ideally, like traditionally it's done like in a sealed envelope, but there's modern technology you can do for this. But in essence, you have a sealed envelope, so you can't see what you're randomized to. That's the allocation concealment, and then having some numeric sequentially system. So it's not like you just open your envelope like, I don't want this one, take another one. You open your envelope, you're stuck with what you got, because if you have someone that you really actually are somewhat concerned about, which in this case was like 7% of people, they seem to have a high pretest for something they were worried about that was clearly not going to show up in renal ultrasound, then you can't just be like, I'm going to choose the CT option. And if I'm the ultrasound person and I love ultrasound and I can't justify doing a CT because I think it's totally inappropriate for this patient, I can't be like, I'm not going to do the CT route. So it's just ensuring that it's not just describing the randomization, it's describing how you can seal the allocation so people actually follow what they're intending to follow.
Yeah, that's a good point. We talked about that too, that a physician preference isn't I mean, they randomized it, but as far as how this would work in the real world, the doc would, pick which they wanted to do first. So it's not completely pragmatic. And the randomization strategy or how they did it is interesting as well. All right. How about Jason's group? You have to unmute, Jason.
Well, it makes it more informative if I do, at least. I don't have to though, right? So we talked about several different things. One of the things we went to was the sort of pragmatic versus explanatory trial. We talked about how, in a lot of ways, in explanatory trials, what we think of when we're think in a more pure form of research in terms of how do we identify the test and kind of say how well does the test perform and what are the barriers. And a pragmatic is really designed to say, well, how does it play with all these variables that are hard to identify and in clinical practice, and how's it going to one site to the next. So it's kind of interesting to think of, because many of the limitations of these studies, aside from like enrollment and reporting issues and methodologic flaws, tend to also be like why you do a pragmatic study rather than doing explanatory study. So we talked a little bit about that, and then we also talked about how the length of stay seems a bit long for point of care ultrasound. And my thought was, and the length of stay for CT seemed far shorter than I would have expected. It's certainly far shorter than it is in my shop right now. So that didn't seem to make me feel better about generalizability. So
I think maybe in 2014, I don't know. It was a
maybe I don't know.
Yeah, I was trying to think back at our shop in 2014. I think it actually did take somewhat less time, because I'm not sure that we were CTing as many people as we do now. So it might have actually taken less time.
Yeah, maybe I don't know, but I was like, that does call the generalizability for the length of stay into question. I think does that apply to 2022? I have a hard time believing that.
Yeah, but remember, a number of the ultrasound first patients went on to have a CT, so that's probably really contributing to your length of stay.
Agreed.
Yeah, because so now you've done the ultrasound and you're going to tack on a CT, so you've really increased your length of stay. And that's kind of what I figured must have been a contributing factor.
Yeah, and we did go a little bit into that. Not that I suspect somebody else pulled this, but I felt like it was very difficult to distinguish like why they went on and got additional imaging, and just didn't really explore that well. And maybe it's just a reporting feature. Given the depth of what all they recorded, I suspect they had the data, and maybe they just felt like they couldn't spill it all in one paper, or maybe they got told to cut it back or what. But I felt like that's the hard thing, is there's some nuance there that's not being conveyed by this paper alone and the results that they share.
I think in the appendices that I didn't send out, that there's actually more information about the second test and that, but I did not send that out to everybody. So good point. Let's see, Matt Tabbitt. How about your group?
Yeah, we had a good chat. We spent a lot of time talking kind of about the paper in general and kind of reviewing the paper and kind of what it meant. And then, like Jason was saying, the difference between a pragmatic versus the, other forms of study, and looking at, how one tells you the data around a certain test and the test characteristics. The other one's like, how does this perform in the real world when, everything may not be ideally set up, as it would be in the explanatory form of study. And so, I don't know, I mentioned this in the group, I've struggled with this paper for years. It just never was that like bright, like boom, earth shattering paper, even though everyone says it was, for me. And I think part of it was surrounded by the fact that I didn't really understand the pragmatic approach at the, and kind of reviewing for this today was helpful in that one. But I also think, what we were describing is like, hey, look, if you want to pick one of these three options, according to the stats, all confounders aside that we've been talking about, each of them seem equally safe in terms of getting to the ultimate, ruling or lowering the risk of alternate diagnoses. And so I think from a pragmatic standpoint, when you don't have a fellowship trained, person at an academic shop, who can give you the ideal scenario, rolling this out to other people who are going to do this with, standard community level training, it's probably safe and is definitely opens the doorway with the right, the right patient, the right patient population, clinical scenario to be able to say this is safe to at least do an ultrasound first strategy. So, but yeah, pretest conditions are hugely important in this paper. You can't just apply this to anybody in the waiting room. So,
All right. And in our group, I'm actually going to let Chris Moore and let's see. Yeah, I'm going to let Chris Moore talk about.
Yeah. I mean, I think we have limited time here. We talked about a couple of things. One, that this gold standard for diagnosis of kidney stone was visualization of the stone or surgical removal, so they reported a CT specificity in the 50% range, which just doesn't pass the sort of face validity test for me. And we talked about the randomization and things like that. And I'll just play devil's advocate a little bit in the sense that, how does the ultrasound really make the difference? And we did some work in this. If you have somebody who shows up, I mean, you'll have a nurse come out and tell you they have a kidney stone, right? I mean, they're at 3 a.m. They're a young guy, nausea, vomiting, writhing around on the bed. I mean, you actually don't need ultrasound for that. You treat them and they get better, you probably send them home. The ones that are where it's actually helpful are the moderate, like maybe it's a kidney stone, and then you see hydro, it's a kidney stone. So that's just an interesting thing. I guess if I had to use time here, I would actually ask Elizabeth Schoenfeld, because I know she's in this area. What are the unanswered questions or next horizons in this field? What do we need to answer next?
That is a great question that I was not prepared to answer, but I wanted to add a few things that I just think that we all need to remember, particularly when we're teaching our residents. A CT scan is not recommended in anyone with a history of stones if they're under 50 and they look like a kidney stone. We should really be trying to avoid scanning them. And we didn't talk a lot about this, but the amount of radiation that these folks have in their lifetimes is actually a ton of radiation. I mean, one of the studies shows that in the year around the kidney stone, the average number of CT scans is 1.7. With about 20% of people receiving more radiation than is recommended in a year, 50 millisieverts. So the radiation issue really should be on our minds, and we shouldn't be scanning people who have a history of stone if they're under 50 and they're not febrile. And then in terms of the study, there were some issues with that, right? Because they didn't exclude people who are febrile, but you guys know that if someone's really sick and you think they have a kidney stone, they do need a CT scan. So they don't necessarily fall in this pathway. And I think that one of the things that people have danced around a little bit that people have said to me is like, I don't know what to do with the results of the CT. I've had non-ultrasonographers say, well, if they have moderate hydro, that means I need to scan them, right? Because I need to see how big the stone is. Or they say, oh, if they have no hydro, I need to scan them, right? Because I don't have a diagnosis. And so people will justify that CT scan any way they can because the CT scan makes them feel better. And the thing that we have to remember is that the CT scan sometimes is for us because the amount of times that it actually changes patient management is pretty minimal. And so you have to decide what your risk tolerance is, and you get your ultrasound and you see what you see. And I want to reiterate Chris's point about looking at the bladder, because the number of times you will actually see the stone is more than you think it will be. And the residents will come and show me 2 kidneys and I'm like, where's the bladder? So always look at the bladder, because if the stone is there or poking out, you've answered your question and you don't need a CT scan. So the question for you is, what's your risk tolerance? And for me, asking about my risk tolerance is not important. The question is, what's the patient's risk tolerance? How are they feeling? Are they willing to take the risk? How big is the risk? And I will say, I think the stone score really helps with that. And it is, I think, pretty simple to remove the race variable from the stone score, but we use it. So I think that it's still a super useful score, and I teach it. But for me, my research is in shared decision making to make this decision. So your patient has to be young and healthy. Your patient has to pee. So you make sure that they're urinating. They have to not have a fever. And then you do your ultrasound. And once you put that all together and you add Chris's work with the stone score plus the ultrasound, you have a lot of information. And you can tell, and you've watched them do their dance, and you can tell them you got a 95% chance that this is a stone. And of these stones, the majority are going to pass on their own. You may need a CT scan. Should we hold on to that CT scan for a little while and use it when you need it in a week or two? Or should we do the CT scan now, running the risk that someone's just going to repeat the CT scan if you haven't passed your stone in 2 weeks? And that really should be the conversation that I think we should be having. But running these studies is really challenging. And so proving that that's the safe conversation to have, that's my goal. And I've been at it for a couple of years now. I haven't shown it yet. So, check back in a couple of years and we'll see where we are. I'm going to put in the chat our decision aid development study so you can see what we did to develop our decision aid. And I'm going to put a link to the PDF of the decision aid that we developed that we're currently testing. So you are not supposed to be using this with patients, but technically you can do what you want. It's a pamphlet. But this is what we're studying right now in our emergency department. And I will say it's very challenging to enroll kidney stone patients before the doctor has decided to do the CT scan. That's one of our big challenges. So Chris enrolled them when they hit order the CT scan, but enrolling them right before that moment is very challenging.
Yeah, and that's the hard place to find, right? Because you can't read their mind. But that's fantastic. I totally agree that shared decision making is this is a great opportunity for it, because there's multiple ways that you can proceed. Elizabeth, have you been successful in getting some funding for the work you're doing now, or?
So we're in pilot phase. We've enrolled 82 patients under a K award, and we're planning an RO1 from AHRQ. So if you feel like your site would be amenable to this, we will be looking for sites for our future study. So I guess maybe I'll put my email address in the chat as well. But this is...
Victoria is the other one you really think of for this shared decision making. I don't know if you ever have tried them, but yeah.
Yeah.
Excellent. All right, I gotta wrap things up, but thank you very much. I think that was a good final summary. So I just wanted to let everybody know that our next session will be on DVT and vascular, and it will be Tuesday, September 20th. Remember, we switched from Mondays to Tuesdays. And our times, 2 p.m. if you're Eastern, 11 a.m. if you're Pacific, and then you have to count off the hours in between. If you're somewhere else in the country, and if you're international, you can figure it out. And we are always looking for volunteers to moderate. So if you want to moderate, be part of our discussion leads, you can email Petra Duran at jax@ufl.edu, and she will connect you with the process. So thank you for coming. This is our entire leadership group. We really appreciate having everybody come and all the great discussions that we're having about these articles. So thank you all very much.